Rheumatoid arthritis. We can diagnose rheumatoid arthritis by checking the articular problems, meaning joint disease. And there will typically be more than 3 joints affected in rheumatoid arthritis in a symmetrical fashion. This means that both sides can be affected equally. So for example, both wrists, both elbows, both the shoulders or knees or the ankles or the hip joints, as you can see on the picture on the left side here. And all the joints can be affected except the dip joint, dip standing for distal interphalangeal joint. And these will typically be for more than 30 minutes. So there will be morning stiffness for 30 minutes, pain. And this is usually for more than 6 weeks. And we have something called Atlantoaxial subluxation, which is between C1 and C2 bones of the spinal column. And as you can see on this picture here, the C1 stands for the atlas and C2 for the axis bone. And between these, there will be a compression of the spinal cord. And if this happens, then neurological disease can happen and can even lead to death. So it's very important to check a radiograph of the cervical spine. And the upper right picture shows that when we have an intubation, for example, when we have a surgical procedure, then the anesthesiologist will put a tube through the mouth into your lung so that the patient can breathe during the operation, meaning the patient gets oxygen during the operation. And when they are putting this tube, there's a risk for the cervical spine compression. So it's very dangerous. So therefore you need a radiograph to check if there is any type of cervical compression in rheumatoid arthritis patients. And usually this will be treated surgically. What about the hands? Here on the right picture, we can see the bones of the hand. So we have distal phalanges, intermediate phalanges, proximal phalanges, metacarpals, and carpals. These are the types of bones we have. And between these, we have certain joints. For example, the dip joint, which is the distal interphalangeal joint, the PIP joint, which is the proximal interphalangeal joint, and the MCP, which is the metacarpal phalangeal joint. So in rheumatoid arthritis, these joints will be damaged. So in the left picture, you can see there will be bone loss and erosion. There will be cartilage loss. There will be an inflamed synovial. There will be a swollen joint capsule. And all this leads to a painful, tender joint. And on the radiograph on the middle, there can be typical signs of rheumatoid arthritis, which is a narrowing, for example, of this cartilage. And Swan-neck is a typical deformity that can be seen. Swan have a typical shape of the neck, and in this disease, it's very similar to that. So as I drawn here with the red lines, you can see the similarities of it. So in this disease, we have the distal interphalangeal joint being flexed, whereas the proximal interphalangeal joint is hyperextended, and the metacarpal phalangeal joint is also flexed. What about Boutonniere? This is opposite. Here you will have the proximal interphalangeal joint being flexed. What about ulnar deviation? In ulnar deviation, we have 2 bones. So of the forearm. So we have the radius bone and the ulnar bone. And the ulnar bone is the one which is opposite to your thumb. Or let's face it another way. The thumb, where you have your thumb, there you have your radius bone. So when you have an ulnar deviation, then it's a deviation toward the ulnar bone. What about synovial fluid analysis? This, if you take a puncture into the joint and then you suck out fluid, you will see this cloudy yellow fluid with more than 5,000 white blood cells per milliliter. These were the articular problems, meaning the joint problem. What about the extraarticular ones? The extraarticular ones means that we have a systemic disease. Because this is an autoimmune disease, it can affect all the organs because your immune system will attack itself. And as we know, the immune system is found almost everywhere in your body. So if the immune system is starting to attack itself, then it can attack almost all the organs. And this happens in rheumatoid arthritis too. So for example, in blood, what can we see in the blood? We take blood and we can find an anemia. And which type of anemia? This is called Normocytic Normochromic Anemia. And why normochromic and normocytic? Because there are different types of anemia. There can be hyperchromic, meaning hypercolored. Chromic means color. So it's a higher amount of color seen in this. Or hypochromic means that there is less color. That's the y-axis. What about the x-axis? That is referring to the size. Macro is big, normal is normal, micro is small. So in this disease, we have in the middle, we have normochromic, so normal color, and normocyte, which is normal size. What about anti-citrullinated protein antibodies? So these are very specific for rheumatoid arthritis. So when you measure these, then it's high likelihood that you have rheumatoid arthritis. What about rheumatoid factors? Almost the same case, but it is not as specific as the anti-citrullinated proteins, but it's very sensitive. So it means that many patients that show up with rheumatoid factors are usually having rheumatoid arthritis, but there are many other diseases that can have also these rheumatoid factors, so it's important to distinguish these diseases from each other. Erythrocyte sedimentation rate can also be elevated, C-reactive protein can be elevated, and then we come to something called rheumatoid nodules. This is also very specific for rheumatoid arthritis. Here you can see a rheumatoid nodule, and this can not only be found on the feet, it can be found on hands, on the occiput, on the extensor surfaces of the arm. It can even be found on heart, on the lungs, so on the inner organs. So it's very important to diagnose this because, for example, in the heart, it can cause various problems, the same with the lungs. So it is very, very important to diagnose this and check with a radiograph. What type of syndromes do we have? Syndromes are collections of symptoms. And usually, typically, doctors talk about syndromes of 3 symptoms, and then they call it triad. So triad, 3 symptoms together making up a syndrome. So if we talk about Felty syndrome, for example, here we can see that we have rheumatoid arthritis together with 2 other things, neutropenia and splenomegaly. Neutropenia is standing for that we have less of neutrophils. Penia standing for less of something. So neutropenia is less of neutrophils. Splenomegaly stands for the spleen being enlarged. Megaly stands for enlarged. So we have a neutropenia, a splenomegaly together with rheumatoid arthritis, and then we get Felty syndrome. What about Caplan syndrome? Caplan syndrome is 2 things together. Rheumatoid arthritis together with something called pneumoconiosis. Pneumoconiosis is black lung disease. This is another name of it. As you can see on this picture here, the lung is typically black, and usually it was because of coal workers where they were inhaling a lot of dust, and therefore you got this black colored lung. Sjogren syndrome is another type. We have 3 things here again: dry mouth, dry eyes, and enlarged parotid glands. So if you look at the pictures, you can see that there's very dry mouth here. The dry eyes can be shown by this paper filter strip, which is called the Schirmer test. And the enlarged parotid glands can be visible on the outside, especially of this parotid gland. So these are exocrine glands giving rise to your saliva. And if this is not working, then you typically get a very dry mouth. What about the eyes? Eyes can be Episcleritis, Scleritis, Scleromalacia, and other types of eye diseases. And this is a typical picture of a red eye. So you need to be aware of this. Lungs, pulmonary infiltrates, interstitial fibrosis, and pleural effusions are typically seen. Vasculitis, we can see that this leg have typically been affected by a vasculitis. So vasculitis is an inflammation of the vascular system. What about the heart? Heart, we have valvular incompetence, so the valves on your heart are incompetent. The conduction problems, so the conduction, your heart is actually having a conduction system which have a problem, so it cannot pump as it should do. Pericardial effusion means that a fluid accumulates around the heart. Pericarditis means that you have an inflammation of your heart. What about the nervous system? The nervous system can be having mononeuritis multiplex, which is a disease of the nerve cells. General symptoms, we have malaise. This is a very typical sign also, but it is constitutional, or it is general. So you cannot really say that if somebody have malaise, then you have rheumatoid arthritis, because it's too general. But we can see malaise in rheumatoid arthritis. The same with fatigue. You cannot say that this is rheumatoid arthritis because of fatigue, but it is present. Weight loss and even anorexia can be seen in rheumatoid arthritis, and this is very serious. So you need to understand that anorexia and weight loss is not only in cancer, it is not only in psychiatric problems. So it is very important to look for other types of diseases too. Fever can typically be seen, but usually a low-grade fever. So now if we go on with the treatment, we can give medications, and medications are the ones which we have to give immediately when we diagnose. And which are those? Disease-modifying antirheumatic drugs have to be given immediately. You don't wait for it. As if you treat rheumatoid arthritis patients as early as possible with these type of medications, then it's a very high likelihood that it will be a better prognosis later on. So it's very important. And which is the most important drug? Methotrexate. If you remember only one thing from this presentation, I want you to remember that methotrexate is the first drug that you have to give in rheumatoid arthritis patients. Other drugs, for example, if methotrexate is not good enough, or if there are contraindications, or if there's side effects, then you give sulfasalazine, hydroxychloroquine, or leflunomide. And usually it is better to give them in combination. So don't give them alone, give them in combination. For example, you can give methotrexate, sulfasalazine, and hydroxychloroquine together at the same time. It's better effect then. Anti-tumor necrosis factor given if these other medications were not enough. So if you had methotrexate and all these three and it didn't work out as it should, then anti-tumor necrosis factor can be given, and this is usually divided into these 5 groups: adalimumab, certolizumab, golimumab, infliximab, and etanercept. As you can see, these medications are usually ending with mab. And what is important to remember with this is decreasing the immune system very much. So it means that you need to check for tuberculosis, latent infections. And tuberculosis is a typical one. So you need to screen patients with purified protein screening. And if you do this and you see that there's no type of tuberculosis, then you can start this therapy. Otherwise, you don't do it. What about non-steroidal anti-inflammatory drugs? This is given together with the disease-modifying antirheumatic drugs. Why? Because the previous medications I mentioned takes around 6 weeks to get effect. So you cannot really say to a patient, okay, wait for 6 weeks to get better. No. You give non-steroidal anti-inflammatory drugs meanwhile, okay? Because these are actually having an effect almost immediately. So it means that when the disease-modifying antirheumatic drugs start to get an effect after 6 weeks, then you start to decrease these ones. What about corticosteroids? Corticosteroids are the choice when the non-steroidal is not really working, so it's not good enough. Then you choose corticosteroids. But it is important to remember that corticosteroids have side effects, so this means that you shouldn't take corticosteroids for too long. What if all the medications fail? Nothing really works. Then usually surgery is the choice. So you go to a surgical treatment with, for example, joint replacement and synovectomy. These are just 2 examples. There are many more. I just wanted to mention these 2. And this is a picture of a total knee replacement. Because of the knee joint was totally destroyed, we had to replace the knee with this total knee replacement. So in summary, we can say that we have these pictures now, which is combined of all the pictures that I mentioned in this presentation. And we can see that the first thing that we have to remember is that it affects more than 3 joints for more than 30 minutes for more than 6 weeks, except the distal interphalangeal joints. It affects in a symmetrical fashion, meaning it can affect wrists, elbows, shoulders, the hip, the knee, the ankles, and so on. What about the radiograph? You need to check a radiograph to exclude atlantoaxial subluxation, meaning that they compress the spinal cord. The fingers are usually in a Swan-neck or a Boutonniere deformation or an ulnar deviation. The synovial fluid can be taken, and then you will see a cloudy yellowish with more than 5,000 white blood cells. It is not only a joint problem, it can be systemic disease, meaning extraarticular problems like anemia, we have rheumatoid nodules, we have the Felty syndrome, the Caplan syndrome, we have the Sjogren syndrome, we have eye problems, lung problems, vasculitis, we have heart problems, nervous system like mononeuritis multiplex, we have constitutional general symptoms like malaise, fatigue, anorexia, low-grade fever. We use medications, and the most important I wanted you to remember is methotrexate, the disease-modifying antirheumatic drugs. Otherwise, we give surgery, and I thank you really much for listening.